Let's look at asthma right quick. The good thing about it is our treatment at our level is the same. Our standard of care for asthma is the same as emphysema and chronic bronchitis. We're going to give this asthma patient a bronchodilator, albuterol, okay? Might give them some Atrovent. We're going to give them a steroid as far as treatment is concerned. We may put this patient on CPAP depending on the severity, right? So that treatment pattern's the same. They'll put a nebulizer, give them a nebulizer with the albuterol. It's going to bronchodilate them. The albuterol is a beta 1 drug, beta 2 drug, so it's going to increase the heart rate. So that's something that we need to know about albuterol, that it's naturally going to, one of the side effects of it is it's going to increase the heart rate, but it's going to bronchodilate, so that person can get more air in, okay? So the good thing is the treatment's the same. We just have to understand a little bit about what takes place. There is a lot of people that gets misdiagnosed asthma. The doctor says, "Oh, you have asthma," so and then they misdiagnose it. You can't grow out of it, okay? Typically, you might have been misdiagnosed with it. However, it's an episodic disease. Episodic means episode. So there's something that takes place that causes the asthma, to trigger the asthma. Here before long, there's going to be something that we're going to do that's going to trigger asthma attacks. If you live in a house, anybody have asthma? Okay. So what's going to take place? Probably maybe this weekend. That's going to trigger asthma attacks.
The weather change.
Weather change. What do we do during the weather change? Both seasons. But we don't turn the heater or the AC on, right? Up in that vent, there are thousands of these dust mites that comes out. Okay. So when that takes place, we have an increase in asthma attacks. All right, if they're not careful. Episodes happen. The episode happens every. I've been here. Every 6 weeks, something takes place that causes to have episodic asthma attacks. What do you think that is? Takes place every 6 weeks.
The end of 6 weeks.
What?
I said at the end of 6 weeks.
End of 6 weeks. What happens at the end of 6 weeks?
Your report card.
You get a report card. Okay. I've seen moms and dads twist down on usually it's their daughters, twist down on their daughter so hard it causes them to have an asthma attack. Stress-induced asthma attack. Right? Girlfriend, boyfriend breaking up, induced asthma attack, episodic, okay? And I'm not talking just pseudo asthma attack, right? These are this person you go out, they're having increased work of breathing, they're really having to work to breathe, they have wheezes, they have bronchoconstriction, and it's all due to a lot of times due to the parents, but
Can asthma be triggered by traveling also? Because sometimes after my mom travels, she get episodes.
yeah, sort of the change in environment, yeah.
But she had it recently, where she had pneumonia, and her asthma was at the same time.
Oh.
After she traveled, so it was pretty bad.
I don't know, could be. Yeah. So we watched the video, right? So it's narrowing of the bronchial, overproduction of mucus, typically causing a constriction there, which is going to cause a wheeze, expiratory wheeze. Staying with Steve, you're going to hear an expiratory wheeze. All right. They have a lot of the same problem. They don't really have a problem. They have a lot of the same problem as that COPD patient. They don't have problem getting air in. They have problem getting air out because of the constriction. Okay, so their SpO2 is going to look okay because they're getting good air in. They just can't get the air out because of the constriction. So you're going to have that wheeze in there. So that might be due to allergic reaction, pollutants in the air, stress, exercise-induced asthma, that's very common. Stress-induced asthma attacks is very common, and they get these allergic reactions to it. So there's your video. There's the picture of the video that you watched. Some of you have the picture in your notes, okay? So this is a normal bronchial, right? You have a muscle layer here, a mucosis layer, which is a liquid, right, film. And then you have the lumen, and it's nice and open, and there's no problem. So something takes place, some episode takes place in this asthma patient, okay? And all of a sudden now they have this inflammation, the swelling of that muscular layer, right? So they have inflammation in the asthma patient. They have an overproduction of mucus, so mucus is released, okay, which is also going to cause some constriction and some problems. Not the same as that emphysema, that chronic bronchitis patient, but there's going to be this overproduction of mucus. And then down here, you have sort of this weird system, and it takes place sort of the same way with allergic reactions. You have antibodies, okay, and then you have these IgEs, something globin, something. Let's call them IgE. All right, that's why we have that beautiful abbreviation. Everybody knows what the IgE sort of looks like. Anyway, they team up with these antibodies, okay, and they float there. But what happens is, on the IgE, is they come in contact with this mast cell. And this mast cell, once this hooks up here, it causes this mast cell to release histamine. And histamine is the cause of one cause of the problem. Okay? The histamine causes the bronchial constriction. So you have the histamine release causes bronchial constriction. That's the same thing in an allergic reaction. Okay? You have a release of this histamine, which causes this. Now you don't have a lot of air getting through there. Okay? Does that make sense to everybody? Now, one thing that we'll talk of a little bit, we'll save it for later when we talk about allergic reactions, because an allergic reaction, someone having an allergic reaction, also has a release of histamine. Okay? But we give Benadryl for that release of histamine. It doesn't stop the release of histamine, it blocks the histamine receptor sites. Okay? But we can't give Benadryl in an asthma attack because of the fact that the albuterol, because that's what we really want, we want that bronchial open, right? If we give Benadryl, it blocks the effects of albuterol. Anyhow, we'll talk a little bit more about that when we discuss allergic reactions. But you get the background in the what takes place. So this normal breathing patient here, nice open bronchioles, gets the report card in the mail. Mom and dad gets home, they go, oh no. You know, and then mom or dad starts turning that screwdriver, and they get excited, they get stressed. This takes place, it starts producing histamines, the bronchial constriction, overproduction of mucus, inflammation, and then they go to the hospital because they're having an asthma attack. They can't get under control. So what they'll do is they'll give them the bronchodilator, the albuterol, Atrovent, okay, A&A, to increase the size of this bronchial a little bit. They're going to give Atrovent to dry the secretions. Right? They'll give a steroid, usually it's Solumedrol, SOL-med, MED, R-O-L is the most popular one, okay? the steroid takes a length of time for it to go take effect, like hours. But there is a property of that steroid which would take a quicker effect. Okay? So the steroid to reduce the swelling. This is why they can't fix it at home with their meter dose inhaler, their albuterol. They don't have the steroid. Some of the long-term asthma medications that people take are steroids, and they're not bronchodilators, they're steroids, okay? They're not an emergency rescue inhaler like a meter dose inhaler. They're for long-term use. So you have to sort of, oh wait, this is not an emergency rescue inhaler, this is steroid. It's going to take time. So they give them the steroid to reduce this inflammation, and then keep the parents away from them so they don't have anxiety, and clear up the asthma attack. So nobody in the United States should die of an asthma attack, but they do all the time. Okay. So anyhow, that's sort of the pathology and the treatment behind asthma. It falls within that whole same sort of treatment line as the COPDs and stuff. So it's asthma. One thing to note, especially on a written test, that if you have a 57-year-old, 60-year-old male having all these signs and symptoms of these respiratory problems, asthma or emphysema? Which one do they have? You got to pick. That's the choices. Do they have asthma, emphysema, chronic bronchitis, congestive heart failure? Those are the 4 choices. Just good test-taking techniques. 60-year-old, asthma or emphysema? Emphysema. In a written test, now there's 60-year-olds out there with asthma, okay? But in a written test, that's one of the giveaways, sort of. The old person has one of the emphysema or chronic bronchitis. You just have to look at the differences in the description that it's giving you. The young person has asthma. So, everybody good? Good with asthma? All right. One more and we'll stop for now. It's going to start happening pretty soon. Pneumonia. So, one year the hospital ran out of vents because they had so many patients having pneumonia. This is single lobe pneumonia. See the spot right here? Pneumonia is due to infection. That's a key. Infection means, what is the patient going to have? Anybody with infection, what are they going to have? Fever. Right? So this pneumonia patient is going to be febrile. They don't have a fever. Okay? Because you want to make sure that you discern the difference between congestive heart failure and pneumonia. Right? Because this fluid here, this infection, is going to produce, it can produce like a crackle. Okay? So all of a sudden now you listen and you have crackles, and if you don't think into it, you don't use those good assessment skills, all right, you're going to think, oh, this patient has failure, even though they don't have a history of CHF. That patient, unless it's an acute CHF, they're going to have a history, right? Because it's chronic over time. So chronic. This patient with pneumonia, okay, you hear these crackles, and all of a sudden you jump off, and you're over here with Steve, and you hear crackles, and you jump off, and you want to give him a diuretic. Guess what you just did? Killed him. Okay? We have to make choices based on signs and symptoms, right? So we don't want to make choice. We want to investigate this. So as we're going through our assessment, this pneumonia patient, do you have a temperature. Body temperature is one of the things that we pick up on. We do temperature. So we do our respiratory rate, our pulse rate, right? Our blood pressure, pain scale, body temperature, right? You can't go to the hospital without getting your temperature taken several times. You can't go to the doctor's office without getting your temperature taken. We'll watch the video when we have a little bit more time when we come back from break. All right. This is one of the MedCram is a good source for review and things. So, pneumonia, signs and symptoms: shortness of breath, with or without exertion. So that's important. Coughing, productive cough, dry cough. They've got something there that's not supposed to be there. The body's reacting, wanting to get that out. Chest pain. Often sharp and pleuric type pain. Did we talk about pleurisy? Pleurisy is it's just an infection of the pleural space, that fluid. What happens with pleurisy is that space dries up. It's a pinpoint pain. They go, yeah, it hurts right here. Okay? Every time I take a breath. Now, cardiac pain is, chest pain is pressure type pain, right? And it's constant, typically. We always have to put that typically in there. Typically, it's constant pressure type pain. This is often a sharp pain, so the quality of pain is not pressure, it's sharp. They're having a sharp pain every time that they breathe, and they have pleuric pain. They say it hurts right here. So this patient would be pointing, it hurts right there every time I take a breath. They point to that. Pleurisy. Okay, so is it pleurisy or is it pneumonia? Right? That's why we take an x-ray. We can see the pneumonia part of it. So this is a different type pain. Respiratory type chest pain is the pain increases with respiration. Again, typically increases with respiration, and it's usually sharp. It's a different type of pain. So now we're having to use those good assessment skills to discern the difference. Is this cardiac pain or is this respiratory pain? Right? Headache, pale, sweaty, fatigue. Why are they fatigued and confused? Why?
They're tired of breathing.
That's a point. They're breathing. The respiratory rate's up there, and they're getting tired of breathing. That's going to equal a vent pretty soon. Okay. Are they? Again, theory. Are they diffusing oxygen right here with all this infection, this fluid, this pus? This is not third spacing, this is pus. Okay, this is an infection. Okay, so they're not diffusing there. Same process, the oxygen can't get through that layer of pus to diffuse. So all of a sudden now they get confused. They're hypoxic, perhaps. Okay. So we look at these signs and symptoms, and then fever and chills. Do they have a temperature? Okay. So you break that. Do they have a temperature? They have pleuric pain or sharp pain. See the way it doesn't even sound like an MI, right? It sounds totally different than an MI. This sounds respiratory. These are respiratory. When we talk about the heart and MIs, I told you we get to this chest pain here that's respiratory type pain. Typically. Are you going to do a 12 lead on this patient? Welcome to court. We think worst to least, right? Worst to least. What's worse? Patient having a STEMI or a patient having a pneumonia? STEMI. So we rule that out, right? Anybody complaining of chest pain, almost anybody, never say everybody. But if you went to the hospital and you were complaining of chest pain, I bet they would do a 12 lead. I know they do one on me. Okay? They did a 12 lead on me because I had food poisoning. I said, you're old. We want to look at your heart. rule that out. Okay, so they rule that out. Everybody almost gets 12 lead, especially the ones complaining of any type of pain up here, belly button up, 12 lead. Let's rule that out. Make sure they're not having a heart attack. Okay, yeah, they're going to get this pneumonia patients. They're going to get a 12 lead. Young people have pneumonia, correct? A lot of young people get pneumonia. It's a myth that if you go outside with your hair wet, not that I have that problem, but if you go outside with your hair wet, that you're going to get pneumonia. That's something your grandmother came up with. That's not true, okay? So, anyhow, the progression, pneumonia, upper respiratory infection, don't take care of it, everything goes south, right? Literally. Lower respiratory infection, bronchitis, don't take care of it, turn into a pneumonia, right? Bad respiratory. Can't see bronchitis, you can see pneumonia. If they had double lobe pneumonia, there would be a pneumonia over here. A friend of mine I went on a trip with, he contracted double lobe pneumonia, thought he was going to die. Okay? So he was intubatable. He was so serious. Fever through the roof. Even though I told him, I said, man, if you wake up with a temperature, you feel like you have fever, you come get me. And he didn't. And we found him unresponsive in a hammock outside. He was trying to cool off. And it's like, oh geez. I mean, he was at death's door with this double lobe pneumonia. Okay, so it was. We got him to the hospital, but that's another story. That was scary in itself. The hospital was horrible. Okay, so we'll watch the quick video after break. But treatment, you do supportive care, okay? They're going to put this patient on antibiotics in the hospital. Maybe if it's really bad, IV antibiotics. They're going to oxygenate them. They can give them some albuterol to open up those airways to help them breathe, okay? But the big thing is they have an infection, so they're going to treat this patient with antibiotics. If it's a simple pneumonia, they may send that patient home, okay? If it's a bacterial, then they're going to keep them. When they do the blood cultures, have you guys seen that yet? The little jars, we'll talk about it here as part of our phlebotomy stuff, the PCT, but they do blood cultures, see if anything's growing in there, bacteria-wise, okay? This pneumonia patient is going to be the person you see on the second or third floor. You don't go give them ice and you say, yeah, why are you in the hospital? I have pneumonia, can't hardly breathe. So hence your part, start that assessment practice, right? And we'll have time to do the assessments here as well. Okay. Questions on asthma? Asthma's pretty easy because we have a good foundation with the COPDs. Pneumonias? Pneumonia? Everybody good? Treatment-wise? So now we've added another two. We've added two more to our list of assessments. Okay? Good.
Great.
Yeah. All right. Thanks, Brett.